So management of pain is a crucial part of oncology. Not all our patients have pain, but some have severe pain, and it can be extremely difficult to manage. And it's a team effort between all the oncologist and the radiologist and possibly a surgeon to find the right combination. Because if your basis of pain management is usually on medical with the drugs they use, but the drugs have side effects, and you use them more and more often. So if you can find something that you can add to that, it's beneficial for the patient. And as I said, we can do nerve blocks. For instance, if you have a specific tumor on a nerve, it can be extremely painful. But if you can find a way of blocking the transmission of pain through that nerve, it makes a huge difference. And that's also minimally invasive, because if we know which nerve to target, we can place a needle right next to that nerve. We can inject a bit of local anesthetic to confirm if the nerve is blocked, that the pain goes away, and then we can, in addition to the local anesthetic, we can add a regional alcohol, and we can do something more permanent to that nerve so it doesn't transmit the pain. There are other forms of intervention also in the pain management. It's, for instance, patients with vertebral compression fractures, whether it's now from a malignancy or from osteoporosis. These can be extremely painful. And one can do vertebroplasty, where you place a needle into that bone and you inject a bone cement, which just supports the bone, and it doesn't fix the problem, but it can take a lot of the pain away. And this is done by orthopedic surgeons, for instance, but also by interventional radiologists, depending on who in the area has the expertise. Follow-up is important for all oncology patients, and the modality of the follow-up is dependent on what malignancy and which organ is involved. But as an example of the breast carcinoma patients, they come for annual mammography. Usually the initial tumor has been removed surgically, but remember, these patients are at risk of developing a second malignancy, so they have to have their annual mammogram. And they have other tests as well. They often have a CT of the neck, chest, abdomen and pelvis to look for any signs of metastatic disease, or if there was previous metastatic disease, we want to see, is it stable, is it responding to chemotherapy, has it resolved completely. We need that information. And these patients are followed up for a long time. The longer they stay disease-free, the larger the interval is between scans. And but the follow-up is important. And then the other reason patients come back is they can get complications of the malignancy, and they can get complications of the treatment. And for instance, if a patient has a pleural effusion because of malignancy, they often come to us for drainage of pleural fluid or drainage of abdominal fluid associated with the malignancy, and that can give them symptomatic relief. So the important thing for SCP is to continue on the way we are doing things, because I think we are an excellent practice, and we've developed ways of doing things as the best we can do them to the highest standard, and we need to keep it that way.